All right, happy Friday to everyone. So we're going to be doing a PTSD informative panel today, which provides a broad overview of PTSD and also some veteran specific tips and factors to consider in treatment. If anyone has any questions at any point, please enter those questions in the chat and we'll get to those at the end of the brief. If the questions are directed at specific speakers, please include the speaker's name in your questions in the chat. Next slide, please. Okay, so as mentioned, this presentation is both a broad overview and specific overview of how to identify, manage, and treat PTSD in veterans specifically. As mentioned, please enter your questions if they pop in your mind in the chat, and we'll get to those at the end of the brief. Next slide, please. Okay, so here's our agenda for the brief and order of presenters for today. Dr. Watters will provide a broad overview of PTSD, and then Dr. Vescera and Dr. Ruzek will get into veteran-specific PTSD tips, recommendations, factors to consider in treatment. Next slide, please. And so on this slide, we have our moderators for the day. Kayleigh, myself, and Nicole will be moderating this event today. And we'll just introduce each other just briefly right now. So Kayleigh Snyder, she received her BA in psychology from Rollins College in 2020. She's currently a third-year student in the PhD program and plans to complete the trauma area of emphasis. Kayleigh conducts research and provides evidence-based therapy with recent survivors of trauma in the early intervention clinic led by Dr. Matthew Cordova and Dr. Josef Ruzek. Her research interests include post-traumatic disclosure behaviors and complex PTSD. Kayleigh currently provides counseling services to students at De Anza College, and she's a student affiliate of APA Divisions 37, Section 1, Childhood Maltreatment, and 56, Trauma Psychology.
Thanks, Colin. I'm going to introduce Colin. Colin Simsarian received his bachelor's in politics and international affairs from Wake Forest University in 2013. He also received his master's in forensic psychology from the University of North Dakota in 2018. Currently, he's a second year as a student in the PhD program and is in the neuropsychology area of emphasis. His clinical and research interests include courage and resilience, global mental health, developmental trajectories, and psychology of aggression and violence, and post-traumatic stress. He is a member of Dr. Bruce Bongar's Clinical Emergencies and Emergencies Research Lab. Clinical Emergencies and Emergencies Research Lab. Yep. He is also a veteran of the U.S. Army and served for approximately 8 years on active duty in a variety of locations. He's a part of ATSS, SVO, and Psychi student organizations. I'm also going to introduce Nicole. Nicole Renee Stevenson has received both a Bachelor of Science in Social Science from New York University, Shanghai, and a Bachelor of Arts in Chinese History from East China Normal in 2019. Afterwards, Nicole received her Master's in Psychology from PAU in 2021 and is continuing her studies as a third-year clinical psychology PhD student at PAU. Nicole plans to pursue both the diversity and community mental health and trauma areas of emphasis. And having worked as an English teacher in Shanghai, China for 6 years, she continues to pursue her interest in teaching as a teaching assistant for PAU's Adult Development and Aging course for master's students. Nicole's research interests center around cultural differences in protective factors against trauma, and she aims to work internationally with underserved communities and expatriates. Nicole is an active student affiliate of APA Divisions 45, which is the Society for the Psychological Study of Culture, Ethnicity, and Race, and 52, which is the International Psychology Division. I'm also going to introduce Dr. Watters. So Dr. Kayleigh Watters is a postdoctoral fellow at Stanford University's Department of Psychiatry and Behavioral Sciences within the PTSD and DBT clinics. Her clinical and research interests include PTSD and CPTSD, sexual assault, self-harm, intersectionality, gender, and college students. Feel free to take it away, Dr. Watters.
think I'm still getting used to being called Dr. Watters. Um, so I'm going to be introducing just kind of a broad overview of PTSD. So just trying to give maybe a little case examples and just like what we do to treat PTSD in general. So I'll have you go to the next slide. Um, I'm trying to figure out just a brief overview of like what is PTSD? What do we think of when we think of PTSD? And it's a trauma related disorder. It is specific to criterion A, so witnessing, experiencing, like confronting with a event that involves actual or threatened death or serious injury or threat of physical integrity. And I think with research, there's always kind of like figuring out like what is criterion A and what does this look like too? And I think I could probably, go on to a whole lecture of talking about what is criterion A and does that really make sense? So, but with my time, just want to kind of introduce that. And then, PTSD has really like these main four components and clusters. So we have this hyperarousal, which is being on guard or alert. It can be a lack of concentration. And then we also have avoidance. I'm going to go into more avoidance later on too, which is just these avoidance of emotions and situations and places that remind the person of the trauma. Whenever I talk to patients and I'm like, do you avoid, emotions or feelings or situations related to the trauma, they kind of look at me and they're always like, of course I do, because it makes sense. Like we're humans and, we're trying to avoid pain. And so I think, with avoidance, we look at it as a, diagnosis criteria. And also it makes total sense, when we think about it. We have the negative change in cognition. So distressing others or the world, blaming oneself for the trauma. I work a lot with sexual assault survivors and we kind of look at, the blame for themselves and, how that maintains PTSD symptoms as well. And also thinking about these negative change in cognition, similar to avoidance, we use kind of this, blaming ourselves to kind of, protect ourselves from future traumas, right? Like if I know I did something wrong, or if I think I did something wrong, then maybe I can change it so it doesn't happen again. So that can also be a way to manage, what happens. And then these intrusive memories. So the repeated disturbing memories or nightmares, or those physical and emotional symptoms when reminded of the trauma. And it's diagnosed after 1 month of the trauma happening. So our next, I feel like I would be remiss if I did not just briefly talk about complex PTSD, especially because it is newly added to the ICD-11 and something that our field is starting to think about more. I was very impressed by the, all of the introductions of the people on ATSS. And so I feel like I didn't really introduce myself, but I am also one of the co-chairs for the complex PTSD SIG for ISTSS. So I do a lot of just looking at and examining how does complex PTSD impact people and trauma survivors. And I think, it can look different. And a lot of times when we work with people who experience sexual assault in their adulthood, they also experience it either in childhood or they have experienced something else. And so, there's this, it's chronic trauma, it's child abuse, refugees, torture, or multiple severe sexual assaultive experiences. It has symptoms of PTSD and also difficulty with emotional regulation or self-concept or relational difficulties. And I imagine anyone who works with trauma survivors probably can see this in some of the patients they work with. And there's also there's, interpersonal traumas are really associated with complex PTSD. And one of the papers that I worked on in Dr. Yelch's lab is examining childhood trauma and seeing that childhood trauma was a huge predictor of complex PTSD. And if we think about this kind of sensitive developmental period, and trauma during this period impacts the ability to regulate emotions and to form a sense of identity. And so working with patients who have childhood abuse, you may want to look at, the emotional regulation that they have and the self-concept and how do they relate to other people. And I'll have you go to the next slide. So my last thing, just to kind of broadly introduce PTSD, is just to talk about, like, how do we treat it? Like, we have this person in front of us who has a lot of trauma, and like, what do we do? So when we think about avoidance, like I talked about earlier, avoidance really maintains PTSD symptoms. That's really what we kind of look at, right? And it's this really like unwillingness to, there's an unwillingness to engage with the traumatic memories or emotions that come up, which in some cases is adaptive, right? If you're a young child and you're being abused by your family and you can't show a lot of emotions, you have to avoid, and these people are there to take care of you. You can't necessarily be like, oh, let me really examine, as a child, what's going on with my caregivers. And so that can be, sometimes just a way to kind of survive. And so instead, patients will try to escape or avoid memories, thoughts, and situations that remind them of the trauma. And this can occur even when it costs something. If you think about a patient who no longer drives because they got into a car accident, or a patient who avoids being around other people or going to events with friends because they're, feeling claustrophobic or really scared and on guard with a bunch of people around them at an event. And it can feel really isolating at times because you can't do the things you used to do. So when we think about treating PTSD, we want to target this avoidance. When we think about PTSD, we can kind of think about it like ice cream, right? There's many different types of flavors of ice cream, and there's also many different types of PTSD, and how can we tailor the treatment to kind of serve what the person's coming up with. So there's a bunch of different possible treatments, and the two evidence-based treatments that we provide at Stanford are prolonged exposure and cognitive processing therapy. So I'll just give brief examples. So prolonged exposure, we really expose the person to the memory and also the emotions that are scary and that come up, and also different situations. So for example, I have a patient who is, he was in a pretty horrific car accident. And he is really scared to drive. He has a lot of hyperarousal symptoms. He has nightmares. He gets panic attacks when he gets in his car. And so there can be a lot of ways in which his life is his symptoms are interfering with his life because, he can't really drive a lot. And driving is really important in California, especially here. So what we're doing is we're slowly exposing him to the things that make him scared. So driving, to different places, driving on country roads, driving at night on country roads. And we think about what is objectively safe. I'm not going to expose him to, driving without his headlights on in the middle of the night, like on a country road. That's objectively not safe. But I want to expose him to something, that is objectively safe, but will probably cause some anxiety. And then he's also doing imaginal exposures with in sessions where he talks in detail about the trauma. So in details, I ask him questions like, what are you feeling? What are you thinking right now? What do you smell right now? Things like that. So that's prolonged exposure. And then cognitive processing therapy is, we really target those like negative cognitions, but we also target that avoidance, right? Where it's like, I feel blame towards myself, and that brings up a lot of guilt and shame and anger, and I try to avoid those emotions. And so we talk about the trauma. We have an impact statement that we go over. Why did this happen? And we bring out stuck points. So, I can bring up a lot of patients because, and I think I'm a little, biased because I love cognitive processing therapy more than prolonged exposure. But cognitive processing therapy with it. So I have a patient who, experienced a sexual assault on campus during the while being under the influence of alcohol. So it's an alcohol related assault. And with those, there's a lot of blame that people experience because, well, I shouldn't have been drinking, or I should have been paying more attention, or I should have said no louder. And so what we do is we target those, and we use Socratic questioning to really examine, like, is that flexible thinking? How can we get that thought to be more flexible? And how can we work on that? I specifically, I have a patient who has a lot of, one of her stuck points is, I should have gone to someone, or I should have been louder. I should have said no louder. And we talk a lot about like, do you have to say, how many times do you have to say no for it to be illegal? And we kind of look at this like legality of the situation, and we look at, all of these different, things that come up with that. There are different types of treatments for PTSD. You can use ACT, you can use written exposure therapy. These are the ones that we use at Stanford. So I just wanted to kind of bring that up. And that is what I have. So I'm going to just give the rest of my time to the other great people who are speaking. So yeah, thank you.
Thank you so much, Dr. Watters, for your great overview of PTSD. We'll be moving on to Dr. Vescera. So let me just introduce her. She's a combat veteran and served overseas in Afghanistan in 2012 to 2013. She spent 10 years enlisted in the United States Army Reserve as a psychological operations staff sergeant and instructor. She received her PhD in clinical psychology at Palo Alto University in 2021, where she studied suicide and resilience factors for service members and veterans. She earned her master's degree in public health from Johns Hopkins Bloomberg School of Public Health, concentrating on public mental health, holding certifications in health communication and health education. Dr. Vescera also received a master's degree in counseling psychology and counselor education from the University of Colorado, Denver. She has published numerous book chapters and articles related to suicide prevention and resilience in multiple settings. She has held a faculty position at the University of Maryland University College Europe and has engaged in several presentations and lectures around military culture, suicide risk, and resilience factors, and other psychological principles. Dr. Vescera is currently working at the Department of Veterans Affairs Center of Excellence for Suicide Prevention in Canandaigua, New York, as a health system specialist, focusing on developing, disseminating, and evaluating national training and education programs aimed at preventing and reducing veteran suicide. So now I'll hand it over to Dr. Vescera.
Thanks, Colin. And thank you everybody for having me. If my audio goes out, will one of you tell me? Sometimes it like cuts in and out, so just let me know because I'm going to start on my roll. So thank you for having me. We'll just go right to the next slide. My job in the next 10 minutes or so is to get us thinking about how to use the evidence for culturally informed PTSD diagnosis, for a PTSD diagnosis to ultimately best treat our veteran patients. It's easy to feel time limited and check the boxes during diagnosis and treatment, but my goal is to see if we can put ourselves in the veteran's shoes during the diagnostic process and be able to connect with their experience. So some of you have seen, most of you have probably seen the PCL-5 and right now the PTSD checklist for DSM-5. The form isn't showing criterion A, but we'll talk about that in a few minutes. And typically the VA uses this as a screener for PTSD. And some VAs fill it out with the veteran. Others had the veteran fill it out, then go back to it. But it depends on the VA. Next slide, please. So the PCL-5 maps directly onto the criteria for PTSD in the DSM-5. And of course, I'm not going to read through all of this. Dr. Watters also gave us a great overview of the symptoms. But what I want to do is look briefly and give some examples of the way the symptoms might play out in a veteran's life and really like get us to feel some of those. So starting with criterion A, which is also called an index trauma, especially in treatment. To kind of put it in a perspective, and something that I do is I think about things that I don't share with other people, not necessarily secrets, but some things I just don't want to share with other people that may be really uncomfortable for me. And I'm sure we've all had that. We have something that we don't want to share with anybody. The difference might be that you or I, it might not be impairing our lives like it may be our veterans. So thinking about meeting somebody for the first time and asking them that something pretty central, whether it's conscious or not, to their lives that they've never told anybody, may be pretty difficult and maybe even impossible. Another example of this is I've known several veterans to describe themselves as monsters after their trauma or several traumas. And they can't see how anybody could possibly love them after what they've done or seen or experienced. So there might be a lot of shame or guilt attached to their stories. And because of that, something that I've used that's been helpful to assess the index trauma for combat PTSD is I'll ask, or I'll just say, tell me about your time in Afghanistan, or tell me about your time in Vietnam, knowing that they went to a certain country like that. That also helps with my fears as a clinician, right? And I'm a veteran too. So, I don't know I'm not a token veteran though. Like I have my own experiences. Everybody has their own experiences. So asking it in that way kind of puts the pressure off me as a clinician and also takes the pressure off the veteran, and they're kind of given that voice for themselves and what they feel like sharing. And then when thinking about assessing for PTSD and military sexual trauma, it might be helpful to maybe ask more broadly about, tell me about your military experience. And that might be a way to help ask that question that could be difficult for both parties. For criterion, actually, I wanted to stop. This too, I wanted to thinking about being creative with this question too, might actually build some trust. An example is that I was meeting with a veteran that could not even give me one sentence about his, we both knew there was trauma there. He couldn't describe it in one sentence, so I can write it down. So what we did, we labeled it, we gave it a name. And so, for example, the name of this was Brown, and it happened to be the last name of somebody that was involved in the incident. And so whenever I referenced it going through the PTSD checklist, it would be Brown. And that's how we were able to kind of work through the rest of the assessment and also into treatment until he was able to get to a point during treatment to be able to describe more of his story there. So it can be important to be a little bit creative too and try to work with the veteran on what would feel most comfortable. So for the rest of the criteria, really briefly, I want to provide a couple examples and how they can be expressed. Re-experiencing, we heard from Dr. Watters a bit about that. One thing I'll kind of jump a little bit due to time, but one symptom within this cluster that we kind of take note of as mental health professionals, we hear this dissociation a lot, this concept of dissociation. And we learn about it in classes and all that, but how this may look, sometimes distractibility. I know a lot of veterans say, oh, I have ADHD, or the whole concept of the 1,000-yard stare, when, even in the room, they'll just kind of look through and past you. And they might be, and that's kind of, to me, it's an opportunity for a conversation about, what was happening there for you. Next is avoidance. We talked about avoiding, and we'll get into that in just a minute with something else. But think about, in terms of avoidance too, and how it affects the daily life, think about planning your entire day around not seeing people, and think about how much planning that has to take. Like, you want to eat at your favorite restaurant, or you want the food at least. So when do you go? Like, do you have to have somebody pick it up for you? When do you have to go to the grocery store? So you have to adjust your whole sleep schedule because you can only go to Walmart at midnight when nobody else is there. So just thinking about how that really could potentially impact people's like daily planning for their lives. So I just wanted to point that out. For criterion D, I wanted to just point out something that was kind of recent in the negative thoughts and feelings. And that's when we recently pulled out of Afghanistan. In my personal little military community, there were a lot of feelings and increases of these symptoms, especially, and existentially trying to find meaning in what their service looked like when they were in Afghanistan. And I'll talk more about this in a little bit. But I just wanted to point that out, that like there could also be current events that also trigger some of these negative thoughts or feelings. And yeah, I'll leave it there. So for criterion E, could we go back one more? I'm almost done. I just have 2 more points on this. And I see that I'm really, really running late. So really quickly, what I'll say here for arousal reactivity, it's very, like that's kind of like the first thing that we see, and maybe family members see and everybody else sees. But one thing about a risky or destructive factor, one point about that is I ask about sex and relationships. I've known a lot of veterans that I've worked with that have actually been dating prostitutes or strippers, or having, multiple sexual relationships at a time. That's something we don't really think or talk about. On the flip side, the benefit to asking about relationships and sex too is that it really uncommon, like veterans don't know about this, but this also, PTSD can decrease libido, even though it's not on the PCL5. And so the opposite could also be happening. So you can learn a lot of information from this, because with a decreased libido, they can feel inadequate, and this could be affecting their relationships too. And it's helpful to maybe normalize that that's actually pretty common in a PTSD diagnosis. And then lastly, I just want to point out the criterion G and symptoms creating distress or functional impairment. An example I'll give, my partner is also a combat veteran. He's been over 1 more time than I have. And he has nightmares. And these nightmares wake me up and really bothers me, right? So in the morning, I'll say, hey, you had a wicked nightmare last night. And he's like, what? I had a nightmare? I didn't even know about it. Didn't bother me. I'm fine. And just thinking about that and how, so for him, nightmares, like he has them, he doesn't remember them. They're not impacting him at all. So kind of being aware too, that some of these symptoms might not, same with isolation. Some people want to live and away from everybody and grow vegetables on a farm and be self-sufficient. If it's not impacting their daily lives and it's not impairing them, there's no need to label them with and slap a PTSD diagnosis on them if it's not impairing them. Now, if he had a nightmare every night, if my partner had a nightmare every night and I wasn't getting sleep, I'm getting cranky, it's affecting our relationship, now we have something to talk about a little bit further. So I just wanted to make a point of that too. Next slide. And I will hurry up. All right. Just a quick, I wanted to point out, I think Dr. Ruzek is going to get into this a little bit more, but I just wanted to point out how the role of values could be really important in thinking about working with any veteran, but also with PTSD. Some people join the military because these values that different branches instill are appealing to them. Some learn them while they're in the service. But for the most part, most PTSD diagnoses do have some sort of moral component to it, and how, like, maybe they went against their values But also maybe the military disappointed them. They joined the military for this, and then the military is the one that betrayed them. So just thinking about a moral component, and again, I'll just briefly say that. Next slide, please. I also wanted to talk briefly about veteran identity, and again, just things to be aware of when you're making these diagnoses. One is developmental, and think about this, a normal term or typical term for active duty Army, you serve 3 years active duty. And so let's say you join at 18, your brain doesn't stop developing until about age 25, right? So let's say in your 3-year deployment, you join the military, you go overseas, you come back, and then you leave. So there's 3 different huge life transitions that happen in just a couple of years, right? And before you turn 25. So think about that, what that does to the brain in terms of its wiring and all of that stuff, before the brain is fully melded, we'll say. Also, dealing with death. This is actually the reason why we train. So it's imbued in everything. All the training that we do is about death and dying. And so thinking about that in terms of how people present, maybe it's with a dark sense of humor. Maybe it's with a more kind of blasé attitude about death and dying. So just something to think about there. Also, the strength of emotional ties to the military. And I put this in because I think about the, anywhere USA, you walk into a VA, you could probably see a Vietnam veteran with the hat, the shirt, the pins, the everything, all the regalia. And maybe this person didn't, he served 2 years during the Vietnam era, but he really identifies with being a veteran. Like he's like all in it. And then I think about some buddies of mine that were in 10, 20 years. And they're like, yeah, I kind of dropped that off at this bus station. That's not even a part of my identity anymore. I am a CEO now, and that's who I am. I'm not a veteran. And so thinking about that's really important, because I think sometimes we have the assumption that like, oh, if they're a veteran, everybody thinks the same way about their identity, and thinking it really on a scale of, where they kind of fall in being tied to that veteran identity. And then also thinking about chronic pain and how this can really magnify some of the symptoms that we talked about, in terms of negative mood, or just a constant reminder, if the injury is tied to their trauma, having a daily reminder every morning when they wake up of their trauma is something to consider as well. Next slide. And then regardless of a PTSD diagnosis, just some things in terms of the combat side alone to think about. I think about my reserve experience and the current wars, and I say current now, it's like, gosh, 10, 15, 20 years ago. But this war specifically used more reservists than ever before. And so really more reservists were being deployed than active duty members. And because of this, if you think about it, so the reservist means for the Army, I serve 1 week in a month, 2 weeks a year. So I go to my unit, do my duty for the weekend, and come home. So when we deployed, we go with our group of people for a year. We come back and everybody spreads out. Most of my unit was in Oregon and Washington, and there were maybe 6 or 7 people from my unit in Colorado at the time where I was living. So that is really, especially for this era of veterans, really isolating if you don't have a unit to come home to, and that disconnected feeling where nobody can actually talk to you about what you went through, and thinking what that means for readjustment, making meaning for your experience, finances, that, active duty, regardless, that kind of impacts you in your transition out. The impact on your family, your mission and purpose, and even employment. For reservists, you're promised your old job back when you return, and that is hit or miss, and how it was actually carried out. So thinking about all those things, and again, it's not so recent anymore. I will stop there. Let me see if there's anything else. Colin, if you want to advance the slide one more, or Nicole. And I'll stop there. If we have time, I want to get to this, but I'll stop to give Dr. Ruzek some time. Thank you.
Thanks so much, Dr. Vescera, for your brief specific to veterans. Now we'll be moving on to Dr. Josef Ruzek. So Dr. Josef Ruzek retired as director of the Department of Veterans Affairs National Center for PTSD Dissemination and Training Division in 2018 after 26 years in the organization. He's a distinguished professor in residence at Palo Alto University. He's edited several volumes on the treatment of PTSD, including cognitive behavioral therapies for trauma and caring for veterans with deployment-related stress disorders, Iraq, Afghanistan, and beyond, and is a past member of the board of directors of the International Society for Traumatic Stress Studies. He specializes in early intervention to prevent the development of PTSD, dissemination of evidence-based treatments for PTSD, and development and evaluation of internet and smartphone-based interventions for trauma survivors. So now I'll hand it over to Dr. Ruzek.
Hi, everybody. Thanks for opportunity to be here and join you. Next slide, please. I'm going to just quickly make some quick comments about things to keep in mind as you begin to think about treating PTSD and particularly working with veterans. Doctors Watters and Vescera have already made a lot of really important points, and I'm going to kind of second some of their points. One is that we heard about the different flavors of trauma, of traumatic experience, and I just want to note that serving in a war zone can bring in a great many different kinds of traumatic events. Obviously, there's death and dying, deathly fear that you're going to die, and a panic and loss of control that means, but also extremely upsetting bereavement experiences, seeing comrades and also civilians die, sometimes grotesque images, being up and close to the man's and humankind's inhumanity to human beings. We heard about the idea of someone labeling themselves a monster, the guilt and the moral injury. Also sexual assault, unfortunately, is very, very common in military experience. And all of this, when people are overseas, is against the backdrop of relentless work and physical exhaustion, which makes it harder to deal with these things. Next slide, please. I just want to put in a quick comment that, we've as mental health professionals, I'm kind of an old time behavior therapist. I kind of never really liked the medicalization of psychology, and we've kind of in the medical model. So I will just say that although it's useful for many purposes to define PTSD as a disorder, in some sense, you can think of PTSD as being a sign that the person's machinery is working correctly. Many of the symptoms of PTSD, like hypervigilance, intrusive thoughts, dreams, even sleep problems, can be seen as a way of the body's way, a biological way, a genetic way of a human organism responding to threat and staying alive. These things probably make someone more able to survive in a objectively dangerous environment, which you are in if you've had these things happen to you. Next slide, please. I also want to point out, it's been said, but one of the, PTSD symptoms are sometimes disabling and disorienting, but the reason PTSD is a problem is that it messes up your ability to function. So you as a therapist want to be paying attention not only to treating the PTSD with PE and CPT and other evidence-based treatments, but also be aware of a number of other problems I'm going to just quickly highlight. One is interpersonal relationships. This is often why people come into treatment, because they're alienated from their families, their children. Back in the Vietnam, veterans used to come in because they wanted to reestablish relationships with their children. Marital problems are rife. And And, you know, people who go through trauma very often are walking around with negative views of other people in the world. Much trauma is interpersonal in nature. War trauma is interpersonal. But also we see emotional numbing, which means people can no longer easily experience positive emotions, but in relationships, they can't express them to their significant other, which causes a lot of degradation of relationships, anger and irritability, and so on, sometimes relative social isolation. So these are the things we need to treat in addition. They may well improve, and I would suggest they do improve with successful treatment of PTSD, but I would argue we should separately target the important ones and also do additional interventions for those. Next slide, please. Also, we've heard a little bit about values, and in particular, how veterans come into military service with often a sense of mission and strong moral commitment to values. And what trauma does, unfortunately, is very often shatters people's assumptions about the world, other people, the goodness of humanity, the fairness of the world, the fact that we all tend to believe that good things happen to good people. Your basic safety, I can protect myself, I can protect my children, my loved ones, I know how to move in the world, nothing bad will happen to me. And then sometimes religious beliefs, God can be thrown into disarray. So those are important. I also will say that in PTSD care, I think one of the continuing weaknesses of PTSD treatment is it focuses on the remediation of negative symptoms of PTSD. I think we should try to focus separately on targeting the ability to experience and have positive emotions, because they're different things, and we can do different things to help people have positive emotions. Next slide, please. Note that the experience of PTSD is quite bewildering to people. You don't know what the hell PTSD is until you have it, and it's pretty weird. You know, you're having panic attacks. The whole thing's strange. The symptoms are weird. You never had these things before. It's mysterious. It's unpredictable. Also, people with PTSD face bazillions of obstacles in life: relationship obstacles, you know, the future, all kinds of physical pain, injury, all kinds of things. The world is full of obstacles for someone with PTSD. And research shows us that the more post-trauma obstacles you have, the more likely your PTSD is to be maintained. So be thinking about helping people with the realistic real-world obstacles and problems that they're facing, in addition to treating the PTSD. Next slide, please. We've heard a little bit how hard it is for people through emotional avoidance to talk to others. But keep in mind, PTSD is a disorder in which people really feel they cannot talk to others. A big one, as we've heard from Kayleigh Watters, is emotional avoidance. You know, you don't want to talk about the thing which makes you feel the worst that you will ever feel in a human life. But also there's all these other barriers. People won't understand the experience, particularly civilians. I don't want to place a burden on them. How can talking help? It's just going to make things worse. And we would often find with veterans coming into treatment at age 70, yeah, they talked about their service bazillions of times. They talked about battles and things like that, but they didn't talk about anything that was upsetting, that would open up their emotions. They never talked about those things. And particularly, they don't talk about guilt and moral injury and those things, because you can't talk about those things. Those are not things to talk about, because they're real things that happen. Next slide. Some comments about treatments. So Kayleigh also talked about PE and CPT. These treatments are important because, you know, a lot of what we do in clinical psychology is a lot of coping skills training. You know, we teach people about social support, we teach them all kinds of skills, problem solving, mindfulness, all kinds of things that are very valuable. But I do not think in general that kind of treatment is optimal with veterans with PTSD. The emotions are just too strong and distressing. They don't go away through most forms of coping. So there's a definite need to revisit aspects of the traumatic experience and make sense of what happened and reduce fear of the memories. Next slide. So the most powerful treatments revisit the traumatic experience. They're called trauma-focused psychotherapies. Why? Because people with PTSD are activated, distressed with extreme intensity, an intensity parallel in intensity to the time they thought they were going to die, or the time they witnessed their friend being blown to pieces. And those emotions are so strong that people come to fear the memories of the emotions and fear the re-experiencing of those things. Unfortunately, in treatment, that means we have to prepare people to be able to deal differently with the memories and be able to tolerate those memories and tolerate talking about the experiences. Also, if people are carrying around these terrible interpretations that they are a monster, they're no longer a member of the human race, that they have done things which are unforgivable, that if anyone knew them, they would not wish to know them or be their friend, those things need changing. If we don't change those, we're not going to be helping them. So, you know, feeling afraid of your memories and feeling overwhelmed by negative interpretations of your life and your experience, that leaves you a sense of ongoing threat, that the world is still a difficult place. And that also is a predictor of the maintenance of PTSD symptoms. So these things are not likely to be changed if therapies don't focus on them. Next slide, please. So we've heard about the CPT and PE. There's also EMDR, and there are a lot of variants these days. People are tinkering with them. There's a new variation of exposure called written exposure therapy, which is 5 sessions, which is easier to administer. And there are people are trying to find ways to make them more efficient, make them more faster, make them more tolerable. And there are a great many of these. But we do want you to pay attention to the evidence-based treatments. Next slide, please. Now, the trauma-focused interventions I'm talking about are not panaceas, because many people just don't want to revisit the traumas. And it's a problem not only for our clients and persuading them to go there, it's a problem for the therapists. You know, therapists don't want to go there. Therapists don't want to upset their clients, and therapists are afraid. And you may well be afraid to, develop the experience in talking with people about their traumas, whether it's in CPT or whether it's in exposure therapy, where you do it in very great detail over and over and over again. Also, these treatments are not absolute solutions, because lots of people drop out of treatment. I was recently involved in this really big trial of CPT versus PE in the VA. And in that trial, there was more than 917 patients, I think, were in it. In CPT, 46% of people dropped out of treatment, and PE, 56% dropped out of treatment. So that's not acceptable. So we need to do better than that. Also, significant percentages of people don't benefit from the treatments, probably because of various forms of emotional avoidance and other things that get in the way. Next slide, please. Other problems with treatment include that, we have problems with help seeking, right? We have stigma. People don't see why treatment will help, how it could benefit them. Those have resulted in Department of Defense and in the VA in huge efforts to tackle stigma and get people into treatment. The best thing we do is that in VA and DoD, we now screen for PTSD with every single patient in primary care medicine. That means that we observe and find PTSD much, much more. We also educate the heck out of everybody about PTSD. Everyone now in America knows about PTSD. Veterans have heard of it. Active duty folks know what it is to some degree, and that's huge. It still doesn't overcome the problem. The other thing that's a problem with treatment, and what quickly want to say, is we don't measure outcomes. So I want to encourage you strongly to measure your outcomes throughout the course of treatment by using instruments like Kristen described, the PTSD checklist. Next slide, please. I'm running out of time, so I'm going to try to speed it up. Next slide. So research is important. I want you to think about paying attention to research, because we need to know if we're really helping. It's, testimonials that treatments are good, that patients like it, isn't really enough. Everybody has a cure. Everybody has a story of something that's benefited. We need to know not only is it helping, but is it helping as much as the other treatments we could provide? So, in our field, there are many wonderful things that are going on now, like equine therapy and working with dogs and forest bathing and a great many things, and many of them are very powerful and valuable. but probably as adjuncts to treatment, because we need to measure those things and see not only whether PTSD improves, but whether it improves as much as if they got an evidence-based treatment. Next slide, please. Jobs are important. My last theme is going to be help your clients, in addition to doing these evidence-based treatments, help your clients with the problems that they're facing in the world. So jobs are very important. Not only does PTSD interfere with the ability to hold down a job and succeed at work, and sometimes to lose employment, but jobs are really important. It's not just the money; it's the sense of contribution. It's moving forward with life, feeling like you have a future. And it's hard to work when you have PTSD: anger, irritability, tiredness, problems with control and authority. The fact you can't be you don't connect at the office party because it gets very difficult for you to be around other people. So we should be paying attention to supporting people with their job performance. Next slide, please. And the problems of veterans and families. What do veterans need problems with? Well, often managing budgets, working out their finances, finding relationships. If you are a young man or woman, you probably are looking for a partner, and PTSD gets in the way of that. Sexual functioning really degrades with people very often, PTSD. We typically don't even ask about sexual functioning. The anger and the violence, the gun safety, and friendships and marital and family functioning. Next slide, please. So clinicians, what should you do? Learn EBTs, learn exposure, learn cognitive restructuring. I recommend learning both of them because they're complementary, and also learn how to do the kinds of things that are in CBT, like homework assignments and how to process assignments, because those are part of the reason probably why psychotherapies are effective. Get in the habit of giving brief measures throughout your treatment process, not only with veterans with PTSD, but everybody you treat. Measure how you're doing. See if they're getting better on the PCL or the depression measures. Stay up on the research if you can, and retrain if the research says so, because we're going to have better treatments. The ones we do now hopefully will not be the best treatments in 10 years. And learn about veterans and learn about the war and military culture. Next slide, please. A couple of resources for you. If you haven't been there, go to the National Center for PTSD website, www.ptsd.va.gov. It's got a ton of stuff. If you're interested in CPT and training, get trained. But there's 10-hour online trainings available for free at the Medical University of South Carolina site in both prolonged exposure and cognitive processing therapy, developed by the originators. And also try out some of the technologies that are very helpful in client and family education. PTSD Coach is great for vets. PTSD Family Coach is great for their partners, their parents, their children, and also the other kinds of apps that are helpful with the related problems. Thank you. I'll stop there and look forward to the conversations.
Thank you so much to our panelists. I know as I was kind of following throughout that you all seem to have more to say, and I wish we had more time. I think we're happy to extend this conversation a few minutes past 1 if our audience and our panelists are okay with that. But now we kind of want to shift to the discussion portion of the event. It looks like we have a question from an audience member, so I'm going to kind of read that aloud, and whoever wants to jump in from our panel first can do that. So we have the question: is CPT beneficial with veterans immediately following a traumatic event, or does CPT work best after some distance from the traumatic event?
Well, I'll take a quick stab. Yeah, we don't know all that much about early interventions after trauma. There's a body of research. Exposure therapy actually performs well in Australia, but so there are not studies of CPT really in the early aftermath. But I will tell you that I would bet my house that CPT would be quite valuable, because negative cognitions are one of the factors that exacerbates and maintains PTSD. There are no trials explicitly of any versions of real cognitive therapy immediately post-trauma in the first weeks that I know of. But I think there's no evidence, and we should remain skeptical, but my guess is that it would be one of the things that would be quite helpful.
Thank you. I think another piece I want to go back to, I know Dr. Vescera had mentioned wanting to maybe come back to this. So maybe we can start with her, but would any of you also like to comment on dual diagnosis? Again, maybe the index trauma and CPTSD were also on that slide that Dr. Vescera mentioned, maybe wanting to talk about again. So if you have anything to mention.
Yeah, I'll just go back to it real quick. So the first thing on my list, though, it kind of all goes together. I wanted to provide a couple examples. The first part on that slide was identifying the index trauma. And I know I'm not answering your question yet, but I'm getting there. But I came across this in my clinical work where I was working with a female combat veteran. She had multiple combat traumas, significant. And we started working on them, and she comes into therapy a couple sessions into CPT and said, so it was really weird. I had this nightmare last night about this memory that I had from my home country. She was born in a different country, and we start talking about it. And it was a childhood sexual trauma that was really upsetting to her, and that this brought up. And so, you know, with me, like I was a student, I didn't assess that well. Like she didn't say anything about a sexual trauma at the beginning, but that was really the most salient trauma. We had to stop, we recalibrated, and we started working with that index trauma. So some traumas might pop up that we didn't know about. And in terms of the other two, the dual diagnoses alongside the complex PTSD, I was working with a veteran. And I knew, like, he was very vocal. He was a very angry guy. But he was talking about the traumas. He wouldn't really touch anything during his wartime experiences, but afterward he had trauma with his buddies. A couple of them he witnessed police assisted suicide. Or I don't know why that's slipping my mind. I'm just trying to go fast, I think. And then we started talking about his previous, like, life before the military, and every conversation, it felt like there was another trauma. And so we're like, okay, I'm like, we have to stop for a second. We actually did a timeline together. We spent a couple sessions doing an actual timeline of the traumatic events in his life that were pretty significant. And the reason why I bring this up with dual diagnoses is because he was seen several times. Nobody wanted to see him. It was really a dual diagnosis for him would have definitely been a borderline personality disorder. So personality with complex PTSD is pretty common. But also there are other diagnoses too that, you know, substance use is big, and we talked about the avoidance strategies that might be one risky behavior. So a lot of these behaviors that or these symptoms that veterans have could also lead to a dual diagnosis, like those two I mentioned. And then they could also be complex in that one could cause the other. So I had a similar veteran I worked with that, in order to avoid, he took meth and had psychosis on top of his already his PTSD diagnosis that he already had. So I will stop bumbling through that. I don't know if Dr. Ruzek or Dr. Watters wants to take more of a stab of that, but I did want to just mention, especially the first topic of that, and then also, if we have time, to talk about the resources. Dr. Ruzek said the next slide that's here. It's, you know, a part of what he said about learning about war and military. I would just recommend in doing that to kind of immerse yourself in it a little bit and kind of try to put yourself in the shoes. And I think some of these resources would be really helpful for you to do so. And they aren't going to be really long, boring textbooks or anything like that. So it'll give you a little break from the textbooks. Thank you.
Kayleigh, did you want to say anything else about any of that?
No, I think that was covered a lot. Yeah.
Okay, I'll just add a quick comment about alcohol and drugs and PTSD. You know, they are highly co-occurring, and as everybody knows, with veterans with PTSD, typically there are a lot of co-occurring diagnoses. PTSD goes along with lots of things. Substance abuse is really a big deal. Unfortunately, the treatment for alcohol and drug problems and PTSD is still siloed in almost all treatment systems, including in the VA, despite the fact that, experts recommend, I don't think the science is there, but experts really recommend integrating the treatments of the two problems. I'm a big believer of that, because if you are actively using substances to a serious degree, I mean, it doesn't mean that there can't be any misuse of substances, but if it's a big problem, it's likely to interfere in your ability to be present and participate in the evidence-based psychotherapies in different ways. And also, if you're trying to get clean and sober, or trying to change something about your drug and alcohol use, if you are not paying attention to your PTSD symptoms or your disruptive memories and all those things, there's very little chance you're going to be able to stay clean and sober in the face of those cues, because those are tremendous triggers, and we need to prepare people for dealing with triggers. So there are some integrated treatments that are being developed. You should be thinking, if you wind up with clients, very often you're going to find these comorbidities. Try to pay attention to making a plan for multiple important elements of what they're experiencing, what their problems are.
Wonderful, thank you. I know we're a few minutes over, but I'm curious, just given that we're all trainees, what might you quickly want to impart to us about our own self-care when wanting to maybe work with, especially as trainees, veterans, and knowing that trauma, sitting and listening to someone's trauma can also really take a toll on us?
I can answer part of that too. So I think, one of the things that I think we all struggle with is just like this idea of like, oh, I can't get emotional, or I can't feel the things that I'm feeling because I have to be strong for the patient. And I think that it's just, I think when people go like, oh, how can you make it? Like, how can you do this job? How can you make it so that you don't feel all the feelings? And I'm like, I feel all the feelings. I work with pretty intensive, trauma histories. And sometimes I work with people and I'm like, okay, I can listen to this and it's okay. And I can go home and, kind of decompartmentalize from that. And sometimes I hear a story and I'm just like, wow, that hit really hard. And I'm really early in my career as a postdoc. I don't know if that goes away. I feel like if my empathy for that went away, then I probably should leave my job. And so I feel like it's like you will have times when it's hard. And I think that that's okay. And I think it's just talking to colleagues. And remember on internship, my colleague messaged me and was like, can you come into my office? And she was just crying. And I'm like, are you okay? And she's like, that was a really tough session. And we just sat there and just talked about it and talked about how hard it is to listen to this sometimes. But so that's, I think just validating that we're human is I think one of the most important things for me. So.
Just to add to that too, really briefly, that I'm kind of close to graduation myself too. I'm a couple of years out now, but something that was I feel like we talked a lot about self-care through PAU and how to do that, or what are tips, like go take a walk or things like that. I found I'm just talking about transitions today, but there is a transition once you do graduate too, in terms of finding what those things are, because they're going to be different than they are now. So just start thinking about it. It was almost like a reverse retirement for me, where it's like, what are the things that I like now that I'm not a student and I'm not doing things for 60 hours, 80 hours a week? Your likes and dislikes change, your hobbies change. Maybe you never, I was like, oh my God, I don't even have any hobbies anymore other than reading. So just thinking about that too, as you transition from being a student.
And I'll just add to Kayleigh and Kristen's comments. I think if you get into trauma work, one of the things that may well happen is you can be deeply shocked because you typically don't know as kind of an ordinary person the kinds of things that happen to each other, whether that's certainly you don't know about war, about the realities of war, and you don't know about the other very bad things that happen. So it does actually often run the risk of shattering your own assumptions. So that's likely to happen. So, the more you learn, invest in learning, learn skills, those are helpful. I would say that it's really, we also have our own vulnerabilities. Like many of you have served, right, as the Student Veterans Association. Some of you and some of us will have been through traumatic experiences in childhood, other parts of our lives. They're not rare, they happen to us. Some of us will have PTSD or partial PTSD. So it's very important, if you have vulnerabilities yourselves, get involved in processing and work them through. Get involved in therapy, deal with them a lot so that they don't come back to bite you, because they're great motivators. They're part of what get us into the work to make a difference for other people, but we also have to do our own work. And I would just second that, it's very important to process what is going on with you as you begin getting into the work. Now, unfortunately, I don't think that's necessarily so easy to do, right? Because it's fine, we all, yes, sometimes we have trusted close friends we can bring it up with, but still you got to do it. It's very hard to bring stuff up, especially if it's the stuff that really bugs you, it really gets to you, is probably the stuff that you don't really want to share. Either it's upsetting or you think it's so goddamn bad that you don't want anybody to really know about it. And it's hard to do with supervisors, right? Because you're maintaining a presence and a facade, right? You've got to look like you know what you're doing, even though if you're like most of us, you feel like a schmuck the whole time as you're faking your way through it, and you probably shouldn't be here in the first place. So, but think about it and find ways to really pay attention to what you're experiencing, because it's a real thing, and it does require attention. Oh, I'll just say that in my family, what it did to me is just made me hyper aware of danger. So I became known as Captain Safety in my family when I had a child, and I'd walk around and lock the doors. And to this day now, this is a bazillion years later, my significant other goes out and I always say, I always give her a little mini lecture on how to drive and leave a lot of room between you. I just can't, because you become aware of the vulnerability in the world.
All right, so we'll do one last question, and it's from, correct me if I'm wrong, Michelle. So considering PTSD co-occur more than not within a transdiagnostic continuum, what is your perspective with evaluation and treatments such as dialectical behavioral therapy plus prolonged exposure and the UP? I'm not sure what UP stands for.
I think I can answer that a little bit. So I work at the DBT clinic and the PTSD clinics at Stanford. So what we do is we evaluate patients to see whether or not DBT-PE, DBT-PTSD, or PTSD treatment is the best for them. I know I'm not familiar with the universal protocol. I know what it is, or unified protocol, so I know what it is, but I'm not very familiar with that, so I won't talk on that. But so DBT-PE, it really depends on what's driving symptoms, right? And what is the extent of symptoms. So when we see a patient in intake, I'm looking for, have they had a recent suicide attempt? Are they experiencing such emotional dysregulation and, distress that they're not going to be able to go through PTSD treatment? And so a lot of times I'm looking for that. And so but also I have a lot of PTSD patients who have suicidal thoughts and they're still appropriate for PTSD. So it's really just like, what is really driving a lot of these symptoms? I mean, and if they're having a lot of emotional dysregulation from the PTSD symptoms themselves, then PTSD treatment may be the best way to start. It's really just like, kind of seeing what's going on. I've had patients where I start PTSD treatment and they dysregulate in such a way that they're, you know, having active plans and intending for suicide. And that's when I'm like, well, maybe we need to do some more PT, or maybe we need to do DBT skills first. And I think, you know, we talk a lot about this in our team meetings of just like, how much do we want to hold, like, how much do we want to like kind of hold back on PTSD treatment? Like, how much do we want to tell the patient, like, I know that you're struggling with PTSD, but I don't want to give this to you yet because I don't think you're ready. And that can be really negative and like, you know, this is something that they deserve. And so, you know, it can be really challenging to kind of balance, like, let's regulate your emotions and also let's treat the PTSD that is interfering with your life. So that's kind of what I'll say about that. I've had patients who, you know, they attempted suicide recently, and they, you know, they need some skills, and they also have some BPD symptoms. And they're dysregulating in a way that they need a lot of phone coaching and they need a lot of distress tolerance skills before engaging in PTSD treatment. Yeah, so that's what I'll say about that. I think it's complicated and I don't have the right answer. So.
Appreciate your input, Dr. Watters. Do any of the other panelists have any input on this question?
I'll just agree with Kayleigh. I think it's a bit of a conundrum because, you know, Marshall Linehan developed it, you know, for people with borderline personality disorder who function so very poorly that they really need a significant preparation, really. But what you see kind of out in the real world of therapy, including in the VA, right, is that anybody with PTSD has tons of emotional dysregulation. I mean, they're all struggling and they're not coping well, right? And also even suicide ideation is extremely common in probably the majority of people with PTSD. Now, remember, the occasional thought or occasional thoughts without ever any intent to do it. You know, suicidal ideation has a huge range. But so you don't want to let yourself off the hook too easy, right? As a therapist, of not wanting to go there because it's uncomfortable, because then we do run the risk of depriving a person from doing a trauma-focused psychotherapy. And if you look in the VA, there's a lot of programs where they want to get people ready for the trauma-focused work, CPT-PE. And by the way, CPT has a version, right, where you don't have to actually go through the trauma itself. However, it's still trauma-focused. And people benefit from it. And there's a lot of research that even people who meet criteria for complex PTSD often benefit from those treatments. So a problem we have is many patients drop out of treatment. So you don't necessarily know you're going to have people in treatment for a year and a half. So, you know, you don't want to, in a way, you know, avoid as a therapist talking about the important issues. But I agree, it's a complicated thing. It takes a lot of judgment, you know, and as you get experience, you're a little bit more comfortable with using it, probably with a slightly higher percentage of clients. But definitely, I'm a big fan of DBT, and I think the optimal treatment for people is usually going to have a mix of DBT, cognitive processing therapy, and exposure therapy. Although, you know, the evaluation studies usually separate them because they're worried about trying to decide which is effective, but probably there's advantages of each of them.
Thank you, Dr. Ruzek, for your input. So Dr. Vescera, do you have anything for this question?
No, leave it to the experts that are treating people right now.
All right, appreciate it. So we'll move on to the next slide, the final slide. Yeah, so we appreciate everyone's attendance here. And we put our emails for our organizations on this slide in case you want to contact us if you have any additional questions. And yeah, I appreciate your time, and enjoy the rest of your day. Thank you.
Thank you.
Like everybody, thank you.
Thank you. Bye.